I'm Shelley Menelacino. I'm a psychiatrist from New York, and I have been involved in this process since last year when I was on the Frank Menelacino Distinguished Lecture Nomination Committee. So I was involved in last year's choice, and this year I was smart enough to get Mark Fleischer on that committee. Mark Fleischer, right here, was smart enough to bring Jarrett Barnhill here, and then from there we expanded this into an afternoon panel. So that's sort of how this has gone. We are involved. My brother Michael's going to speak at the end about our foundation and sort of what the goals are in the future. So, I needed to start actually. We forgot at the, oops, wait a minute, let me go backwards. I was supposed to say a few things. The usual, but yes, well, it's very important that this has really been Creighton and the University of Nebraska and Monroe-Meyer and the state of Nebraska, Region 6, and the National Association for Dually Diagnosed. So it's been a broadly sponsored event, and especially this afternoon event. That's all the broad sponsorship. So that's who we are, and we hope next year that it'll be a full day event. All right, there's, okay, the usual, but the evaluation attendance, we want your input. Please complete the evaluations and return it. And if you need CMEs, I think you'll probably know what to do. And the sign-in sheets are separate for this. This afternoon is 1.5 hours CME, and earlier it was 1 hour. So the total event is 2.5 hours CME, and it's free. So that's sort of what we have been about, is how to as a group of sponsors, make this kind of thing available. Okay. I'm going to first give this plaque to Jarrett Barnhill. And this was supposed to have been given at the noon lecture. I really enjoyed the lecture. Where is he? There he is. So if you'd come up. So the distinguished lecturer has a small stipend with it, so he got the stipend. The rest of the crowd here has come without a stipend. They came because we asked them to come. So let's see, I'm going to first start with Steve Rudrick, down here. Steve Rudrick is a psychiatrist. He was at the University of Nebraska Department of Psychiatry. He was there when my father was there, and when I went to medical school, he was in charge of the medical school training. So he was my mentor as a medical student, and he was a mentor for many of my friends. And I feel, in some ways, I know my father was a mentor to many people, but given he was my father, I wouldn't say he was my mentor. But I certainly have seen the role of mentorship, and one of the things we, as an umbrella here, hope to do is find ways to provide mentorship by inspiring other professionals to get interested in this arena. We had a dinner last night. It was shocking to see how many people were involved by somebody else in the room, that the mentorship sort of was 3 generations. And I think there are a lot of people remain here in Nebraska who are potential mentors, and actually, so that's really one of our foundation's goals, is to really foster mentorship. So anyway, back to Steve Rudrick. He was my mentor, and he left Nebraska, went to Case Western, and been involved in residency training many years in his full-time practice, and actually he works in exactly this area, treating individuals with developmental disabilities. So here's Steve Rudrick.
I'm delighted to be here. I'd like to thank all the sponsors. I'd like to thank Dr. Wilson and the University of Nebraska and the NAD, and particularly the Menelacino family for having me. It's been a joy and a delight. I hadn't been back to Omaha for a number of years. Love your city. Just it's great to be here, and I appreciate the opportunity to talk. My remarks today are going to be brief. I'm kind of the setup person for the rest of the afternoon. And I'm going to talk a little bit about intellectual disability, and then hopefully set this up for the next speakers. Oops, that's not a good thing. The title here is Intellectual Disability, at Last. And it was these slides are a part of a larger presentation from a couple of years ago when our field was making its transition from the old pejorative term mental retardation to the newer term intellectual and developmental disabilities. I'm old enough that those old terms still kind of come out sometimes. So you can, if I say that, you can boo and I'll get the message. But as you know, we're now treating and addressing individuals with intellectual and developmental disabilities. And so 4 brief topics. One is the challenge of treatment in this area. I'm going to talk a little bit about the introduction to ID and the dual diagnosis. Talk a little bit about psychiatric person power. How many psychiatrists are psychiatrists in training? Good part of the crowd, good. So that I'm really talking to you and with you, I hope. And then finally, is there anybody here from the American Psychiatric Association? Good, so I can jab them about what they're not doing about our area of psychiatry. I'm going to finish with the APA and person power. So here's the challenge. This is a quote from Potter back in the 20s, almost 100 years ago. We like to imagine that psychiatry will sometime in the future give mental deficiency the attention she is so much in need of. Have we come very far in the last 100 years in addressing this in psychiatric education? And then this quote from David Satcher as the Surgeon General about 10 years ago from Closing the Gap. If you get to know and work with people with intellectual and developmental disabilities, you'll like it, but you have to get to know them. You have to work with them. You have to be in a circumstance where they become a normal part of your educational circumstance. And there's pretty good evidence that if we expose students and trainees, residents, across the spectrum of training to individuals with IDD, they like it and they're likely to stay with it. We still have many challenges. So the challenge that I'm going to talk about today is to interest and educate a sufficient number of psychiatrists to meet the mental health needs of people with intellectual disability. And we're going to talk about why we haven't kind of quite gotten there yet. The reality is we need a lot of help to meet that challenge. I'm going to show you some comparisons in a few minutes between the US and the UK. I have significant Brit envy. The British, the UK, and parts of Europe are way ahead of us in this field in terms of the attention and training they give to this area. But you need to know that what we call ID, they call LD. And intellectual and developmental disability in this country is learning disability in the UK and much of Europe. So what journal you're reading and where it comes from and who the publishers are determine which one of these top terms you're going to need to get familiar with. So our ID is their LD. Here's the scope of the challenge. Depending on how you define it, 1 to 3% of the population has an intellectual or developmental disability. That's a lot of folks. A very conservative estimate, if you say how many people in a given geographical region are being identified and served, it's usually about 1%. 1 person in 100 is a conservative estimate of the people that we serve. So on to the ID and the dual diagnosis. The concept of the dual diagnosis started right here in Omaha, Nebraska. Individuals with ID are subject to the entire spectrum of psychiatric disorder. This is a novel thought 30 years ago. I'm going to go 2 slides ahead, 3 slides. Because of this, before the concept of the dual diagnosis, almost everything a person with an intellectual disability did, or whatever way they were, was ascribed to the intellectual disability. So if you sat in the corner and cried all day, well, it's because you have an ID. If you stayed up all night and ran through the hallways of your home, well, it's because you have an intellectual disability. In the 1980s, it was a novel concept to think that a person with an intellectual disability could have a comorbid psychiatric disorder that might account for a lot of those things. And this concept of the dual diagnosis of intellectual disability and psychiatric disorder is attributed to the man that we're here to honor today, Frank Mendelacino. He is credited with the concept, identifying and defining the concept of the dual diagnosis, something we in the field take for granted today, but really has only existed in our thinking over the last 30 years or so. And this is one of my favorite pictures of Frank. He was all of these things and many more things, and Dr. Fletcher is going to share some more of those things in his presentation. He left us way too early. Shelley talked about mentors. Dr. Mendocino was clearly a mentor of mine. I was saying last night he still kind of sits on my shoulder and advises me about the work I do with patients that we see every day. And the thing that I think that he was most of all is the one in the lower right-hand corner there. He was a dreamer. We talked about this. Here's the prevalence of the dual diagnosis. We're talking about a lot of folks. We think that, and if you look at big epidemiologic studies of either populations of people with ID or populations of people with psychiatric illness, it looks like there's this overlap of somewhere between 25 and 40%. So that when I talk to residents in psychiatry about this, I say if you don't get anything else from what I'm talking about, remember the 1/3 rule. Every third person you see who has an intellectual disability probably has a comorbid psychiatric disorder. The 1/3 rule. On to person power. This is a schematic of the United States with a population of roughly 300 million people. If we apply those fractions that we just talked about, people with ID are about 1% of the population, or about 3 million of that 300 million. And people with an intellectual disability and a dual diagnosis, the ones that we all serve and work with every day, we're talking about 1 million individuals in our country. And so my question is, well, where do those 3 million people with developmental disability live? And then where do those 1 million people with ID and the dual diagnosis reside? The truth is that most people with intellectual disability have always lived in the communities that they are from. At its height, at the peak of the institutional movement in our country, about 200,000 adults, primarily some children, but mostly adults, were living in what were called congregate settings. That is, a place that held more than 16 individuals. So in the late 60s, when this peaked in the area of intellectual disability, we had about 200,000 people living in institutional settings. By 2006, about 40 years later, there were only 173 of these facilities in the United States. This is an older slide. Probably if I updated it, it might be down to 150 or 140, because all of the states are downsizing and putting people out into the community. 9 of the 50 states have no state developmental center as of 2006. They had taken all of the individuals in their states and put them in community settings. So if you look at the census in 1960s, we were at about 200,000. By 2006, about 40,000 individuals, representing an 80% deinstitutionalization of people with intellectual and developmental disability. And as those of us who work in the psychiatric field know, because of people like you, because of people like Frank, because of people like Jack Stark, I see, Mr. Mason, I don't know if he was here. If he's here now, he was here last night. And all of you, this has been a much, much more successful deinstitutionalization than what has taken place for people with psychiatric disorders. We made sure, you made sure, you're making sure every day that as people have moved out of the institution, the community is taking them and accepting them and treating them in community settings in a much more successful way. We've done a very bad job in this country of deinstitutionalizing or transinstitutionalizing people with chronic and severe psychiatric disorders. We've done a fairly good job. I would submit that perhaps an excellent job of deinstitutionalizing our people, the folks with intellectual disability. So if we go back to these numbers, if we say about 1 million people in this country have an have a dual diagnosis, and we subtract the 40,000 or so of those people who are still living in an institutional setting and perhaps getting specialized care in an institutional setting, that still leaves 960,000, almost 1 million people who are with dual diagnoses living in the community. And so my question today, and we can think about this a bit, is who will serve these people? Who are going to take care of those people living in the community? Is there enough psychiatric person power to meet the needs? And where should the field look for evidence that there are psychiatrists willing and able to treat these patients? And so quickly on the heels of that question is the corollary question, which is, should this field be a psychiatric subspecialty? Should people who work in the field of dual diagnosis be subspecialist psychiatrists, like we have child psychiatrists, we have geriatric psychiatrists, we have adolescent psychiatrists, we have forensic psychiatrists. Should the field be a specialty in psychiatry, or should this be something that a generalist psychiatrist does? And then, if it should be a specialty, is there any evidence of that specialization in the United States? This is why I ask about the APA. The APA, our union, the American Psychiatric Association, has about 35,000 psychiatrists today. There's an estimate that there are another 20 or 25,000 psychiatrists who are not APA members, for a total somewhere in the ballpark of 55 to 60,000 psychiatrists in the United States. And so if we do the math, if we take that 960,000 patients with a dual diagnosis and we divide them by the 55,000 or so psychiatrists in the United States, and actually this is a typo, that number should be 17.5. Let me see a show of hands of the psychiatrists or psychiatrists in training. How many of you have 17.5 individuals with a dual diagnosis in your practice? One does. Not many, and here's the reason why.
I saw Jared's hand.
Oh, two. And I'll raise my hand, three. We're not doing the job here. We're still kind of, we need help, the challenge I talked about originally. If we look for evidence of subspecialization in this field, if we say, okay, the generalist psychiatrists are not doing this job and taking care of that million people with a dual diagnosis, where would we look for evidence of subspecialization? Well, these are some organizations and other bodies, political bodies, that might help us treat patients who have the dual diagnosis. There's the APA, American Psychiatric Association Caucus of Psychiatrists treating people with DD. There's the NADD, Dr. Fletcher, its CEO, is going to talk about this, an organization specifically dedicated to the individual with dual diagnosis. There is the broader, bigger association, the American Association on Intellectual and Developmental Disability, which includes not just medical types, but psychologists, educators, administrators. There's the Child Psychiatry Group, the American Academy of Child and Adolescent Psychiatry, has an Autism and ID committee that meets. And then finally, there's a relatively new organization called the AADMD, the American Association of Developmental Medicine and Dentistry. And I'm going to give you some numbers from these organizations, kind of in the order that they appear on this slide. In the past, back when Dr. Mendelacino was working in this field and around in the 60s, our APA took a survey of American psychiatrists asking, what's your job? What do you primarily do? And at that time, of about 16,000 respondents, almost 1% said they worked primarily in the field of intellectual and developmental disability. The numbers have gone down since then. Here's the present. In our American Psychiatric Association, the APA Caucus for Psychiatrists Treating People with ID and DD, this was a subcommittee born in about 2000 under the direction of these two clinicians. Currently has a listserv of about 100 persons on the listserv. And if you go to an APA meeting and you look up the lunchtime meeting where the APA caucus in this area takes place, I've been there when there were as few as 5 people in the room, up to about 30 people in the room. So we're a small club. If you look at the NADD, and Dr. Fletcher can help me with these numbers, about 1,400 members, roughly, about less than 100 psychiatrists, 80 to 85 psychiatrists, members of the NADD. If we look at the bigger organization, the AAIDD has a membership of about 4,500, physician members about 200, psychiatrist members about 75, probably the same 75 or 80 that are NADD members. So I at least am in both of those groups. Count me twice. If we look at the child psychiatry system, the American Academy of Child and Adolescent Psychiatry, Autism and DD Committee, committee membership, 12 to 15 folks, attendance in an annual meeting, 10 to 15. My wife is a child psychiatrist. When she goes to the ACAP meetings, I sneak into this committee, even though I don't pay the membership to belong to the ACAP. I'm not a child psychiatrist. But I find a way to get to this meeting. I've been there when there were as many as 20 people in the room. Typically, about 5 of them are lost and thought they were going to a different lecture and wandered in. But the other 10 to 15 of us there have something to do with autism and developmental disability. And the newer organization, the AADMD, is just getting off the ground. These are primarily, not many psychiatrist members, primarily internists, family physicians, and dentists who work specifically in our field of developmental disability. So what's my point? Fairly anemic numbers. Going to the APA and person power, here's one of the reasons why. If you look at the requirements for an accredited residency in psychiatry from what's called the ABMS, the American Board of Medical Specialties, there is currently no requirement for any experience with people with intellectual disability in psychiatric residency training. It's not in there. I've looked at this as recently as last year, and there is no requirement. As a result, many general psychiatry residency training programs have almost no training in intellectual and developmental disability. So many residents have little or no formal didactics nor clinical experience working for people with in this field. So that most of the work most people who end up working in this field end up with what I've referred to as on-the-job training. You come under the influence of an influential mentor, a Dr. Mendelacino, get excited about the area and kind of end up doing this kind of work because there aren't, before I go on to the next slide, show of hands. How many accredited fellowships in intellectual and developmental disability psychiatry in the United States? Anybody? 0. How many unaccredited fellowships in intellectual and developmental disability in the United States? 0. To my knowledge, and I ask this question at every meeting I go to, I ask for somebody to say they've got a accredited, unaccredited, partially accredited, just got started, something, fellowship in intellectual and developmental disability, and there's definitely silence like there is here today. Number of accredited fellowships in ID in the United States, none. Number of I put a question mark because I'm always hoping somebody's going to raise their hand and say, we got one over at our university. But today, the psychiatry of ID and dual diagnosis is not a recognized subspecialty by the American Board of Psychiatry. Now, the situation is a little better in child psychiatry because in the RRC requirements for child psychiatry, there must be an organized teaching and clinical experience in pediatric neurology. That now says ID if you actually go to their website rather than the old term. So if you're in child psychiatry residency, you will have some contact if you're in an accredited residency, or if you don't, your residency risks being unaccredited if you don't have some contact with this patient group. The closest thing to ID training that's recognized by the board is something called neurodevelopmental disabilities, which is really considered a subspecialty of neurology. It was approved by the American Board in the late 90s, had its first qualifying exam in 2001, and so far that slide's a little old too. It's about 70 neurologists have now been certified as having board certification in neurodevelopmental disability. There is no psychiatric pathway into this. The way into this subspecialty is 2 core years of pediatrics followed by 4 years of neurology. So the psychiatrists, by being psychiatrists, are essentially excluded from this subspecialty. And if you ask the American Board, here's what they say. The board will support the development of a new subspecialty if there are at least 500 psychiatrists or 100 neurologists willing to practice in that specialty. So the neurologists are well on their way to that 100 figure, and they will have their subspecialty. If you compare the numbers we talked about earlier in terms of the numbers of psychiatrists in the field, we're quite a ways from that 500 subspecialists. Let me contrast that and wrap up my little part of this with the United Kingdom. In the UK, all senior house officers must have an experience in ID or learning disability before they are admitted to the Royal College. Being admitted to the Royal College is the British equivalent of what we call board certification. And you have to have an experience in this area if you want to be board certified in the United Kingdom. And ID is actually one of the 6 recognized subspecialties in psychiatry in the United Kingdom. Here are some figures. In England in 2002, there were 174 LD subspecialists, each responsible for a catchment population of 228,000 people. In Scotland, not quite as big. And the Royal College said they recommended that there be one learning disability psychiatric consultant for every 100,000 persons. That's not 100,000 patients, that's 100,000 persons in the population. That one ID or LD psychiatrist ought to be able to meet the psychiatric needs of a population of about 100,000. That's their recommendation. If you extrapolate that number to the United States and our 300 million people, the RCP ideal ratio there, we would need 3,000 psychiatrists to meet the mental health needs of people with intellectual and developmental disability. If we did it, England isn't there either. Their numbers are currently about 1 per 220,000 people, so they have about 1,300 or so individual psychiatrists identified with this as their area of expertise. I'm almost done. So the generalist versus specialist conclusion I come to is that in the United States, subspecialist credentials in ID are self-recognized, obtained through on-the-job experience, and infrequent. As a result, most psychiatric care of people with ID and DD is provided by generalist psychiatrists, some with on-the-job training and experience, but most of whom feel inadequately prepared to treat these people. Let me come back to Dr. Mendelacino. He began a legacy in this area of addressing the needs of this patient population. And I think that a fitting and appropriate legacy for his foundation and his work going forward would be for his students, supporters, and colleagues to fulfill his dream of providing quality psychiatric care for all of those individuals with the dual diagnosis, which he identified and named. Thank you very much.
Next is getting his microphone on is Dr. Wayne Fisher. Dr. Fisher is here in Omaha. I don't know. He actually got recruited from the East Coast, from Johns Hopkins, and he's the psychologist today. He's a very impressive researcher, and he's going to talk today about behavior research. And I'm not sure exactly how much he's going to show, but his work is really important. As Steve was saying, how are you supposed to know when somebody has both, say, autism and bipolar disorder? How are you going to, there's too much information as a clinician. How are you going to be able to understand what's going on? And he's going to talk to us about that.
I'm from the Monroe-Meyer Institute here at the University of Nebraska Medical Center. And I want to thank the Mendelacinos and everybody else for inviting me to participate. We had a nice, very nice dinner with lots of good conversation last night. It was very enjoyable. Discovered some connections we didn't know we had. That was kind of nice as well. So it's an honor to be here, and I greatly enjoyed Jarrett's presentation. I was amazed at how much could be covered in such a short period of time. It would take me probably months, and I'd still have to do some studying before I covered all those topics. So I'll be a bit of a contrast in that I will be talking at a much more focused subject. And the topic I'm going to be talking about is understanding aberrant behavior in individuals with autism and developmental disabilities from an environmental or a contextual standpoint. And to help explain what I mean by that, I tell a little story, and that is that there was this man walking in the woods, and he stumbled upon this object, picked it up, rubbed it, and it was a lamp. And as he rubbed it, a genie appeared, and the genie said, "I've been in that lamp for 3,000 years, and for your reward for releasing me, I'll grant you any 3 wishes you want." And so the guy thought a little bit, but he said, "Well, you know, my health's been kind of bad. My knees hurt. A doctor says my heart's not doing that well. You know, I've got aches and pains just about everywhere. It'd be nice to feel healthy, feel good again." And the genie says, "Poof, your wish is granted. What's your second wish?" And he said, "Well, you know, I've been poor all my life, never been able to travel or do things because I've really never had any money. It'd be nice to have a little bit of money and, you know, feel a little more comfortable financially." And the genie says, "Poof, your wish is granted. What is your third wish?" And the Guy thought for a long time, and finally he said, well, you know, it would be really nice if my sex life would improve a bit. And the genie goes, poof, your wish is granted. So about a month later, the guy's walking through the woods again, and he comes upon the genie, and the genie says, well, how did the wishes go? You know, I was in the bottle for 3,000 years, and I want to make sure that everything went okay. And the guy says, oh, great, I feel great. I've just been to the doctor. He gave me a clean bill of health. My heart's better, my knee's better. You know, I'm jogging, I'm running. I've never felt better. And he says, what about the second wish? And he says, well, geez, I apparently had this rich uncle, and this uncle passed away and left me a fortune, so now I can do anything I want. I never have to worry about money again. And so the genie said, well, what about the third wish? He says, oh, just terrific, man. I'm having sex every other week or so. The genie kind of scratched his head and said, every other week or so? Well, my wishes usually come out a little bit better than that. And the guy said, well, it's not bad for a priest in a small town. So in looking at anything, it's important that we understand the context in which the data that you're looking at is presented. And I apologize to anybody that's Catholic in the group. Okay. So what I'm going to be talking about is data-driven and individualized behavioral interventions for individuals with autism. And this presentation on those folks that have been deinstitutionalized over the years. The group that I'm going to be talking about today is the group that still is at greatest risk for either remaining in institutions or being placed in an institution because of severe aberrant behavior. And so in terms of autism, since we've already covered a lot of this today, I won't spend a lot of time on the specifics. But the group that I'm talking about, generally, the vast majority of them meet diagnostic criteria for autism, but that isn't their central problem in being able to function in communities and community settings. And so the approach we take is called a functional approach. That is, what is the function or purpose in the context in which behavior occurs that may be contributing to the problem, and how can we use that information to better develop effective interventions. And so if we think about a structural approach to diagnostic and nosological classification, we diagnose autism because individuals have a set of symptoms that correlate in terms of language and communication, in terms of social interaction, and in terms of repetitive activities, interests, and behaviors. And when an individual has that cluster of symptoms, we make the diagnosis of autism. But that diagnosis doesn't tell us a lot about how to proceed with an intervention. And that doesn't matter if we're talking about a behavioral intervention or a drug intervention. We still have to look at what is the presentation, what are the targets, what are the individual things that we're looking at in order to try and figure out what is the thing that we should be using, or a set of things that we should be using for intervention. And so our functional approach looks at what's going on in terms of the individual's behavior and how they interact with the environment, and how is that, if it is, how is it contributing to the problem behavior, and how can we use that information to design more effective interventions. And so functional analysis identifies environmental contexts in which aberrant behavior is likely to occur and unlikely to occur, and it is designed to identify the antecedents and consequences in those environments that may be contributing to the problem, so that we can use that information to prescribe effective treatments. And if you think about it, it is actually a rare individual that displays aberrant behavior all day long in all types of environmental and social contexts. Occurs at high rates in certain situations and at much lower rates in other situations. And so if you have that variation of an individual's behavior, it is reasonable to assume that there are different things that are going on in the environment that are triggering it at certain points in time and not at other points in time. And so if we can understand those environment behavior interactions, we can design more effective treatments. And the most common things that we look for are things that involve social positive reinforcement, where problem behavior leads to attention. Many of the individuals that we deal with don't have effective ways of communicating, don't have effective ways of getting attention, and they may do something inappropriate, cry, scream, or even hit themselves, and just about any parent is going to drop what they're doing and try to figure out, what do I need to do to stop this child from engaging in problem behavior? And so they may pick the child up, rub them on the head, and for a child for which adult attention is highly reinforcing, the child may learn that the thing to do when you want mom or dad's attention is to hit yourself. And many of the kids that I deal with probably don't think through that verbally or logically like I just did, but they may learn the association nevertheless. Another common thing that we see is a child is displaying inappropriate behavior, and a parent may do something to try and calm the child down. So a child is banging their head, and we may turn on music to soothe them. We may turn on the television, maybe give the child their favorite blanket, give the child something to eat. Those tangible types of things, again, if that happens over and over again, the child may learn that self-injurious behavior or aggression or other types of problem behaviors are effective ways of influencing one's environment. And our children that have very poor ways of recruiting attention, of recruiting access to preferred things, self-injurious behavior and other types of aberrant behavior may be very powerful ways to control one's environment. Another common thing that we see when kids start learning things and we teach them things, we attend them to school, is that these are often individuals that we don't teach by standing up in front of a slide presentation. Very frequently we get with them and say, this is how you fold a towel. We help them, we grab this hand, and we guide them through the activity. And for a child with autism, having somebody close to you, hovering over you and doing this sort of thing may not be their favorite activity. They may do something inappropriate, throw the materials off the table, try to bite the therapist or the teacher, or even hit themselves. And the natural reaction of a teacher or parent in that type of situation is to back off and give the child a chance to calm down. Well, if this happens over and over again, what the child may learn is, if I want these people to go away and leave me alone and take this not so fun stuff away, the thing to do is to hit yourself. And again, that doesn't necessarily happen by the person logically thinking through it, but they may learn it from repeated exposure and experience. Okay, another common mechanism that we see has been called automatic reinforcement or sensory stimulation. And what we see is, we did a study on the first 100 cases of self-injurious behavior seen at the Neurobehavioral Institute, at the Kennedy Krieger Institute at Johns Hopkins. And one of the interesting findings we found was that in individuals who had significant visual impairments, but who had intact sensory neural pathways, they were 16 times more likely to have self-injurious behavior involving the eyes. Why do you think that is? Well, if you are deprived of visual stimulation all day long, and you happen to press or push on your eye, it produces visual-like sensation in the occipital lobes. And so for someone who's deprived of visual stimulation, this may be a highly reinforcing effect. And so what we see is a much higher prevalence of self-injury involving the eyes because of this. And that would be an example of automatic reinforcement. The behavior produces some sort of sensory or reinforcing consequence in and of itself. We scratch in order to relieve an itch. People do a variety of things to produce what we'd call positive reinforcement in the form of self-stimulation. Kids with autism very frequently appear to be reinforced by doing repetitive activities that involve spinning objects, turning the wheels over and watching them spin. Those are things where the behavior produces the reinforcing events without us interfering or socially getting involved with it. Okay, so to give you an example of some examples of the types of individuals we work with, I said before that it's really a rare case that an individual displays these problem behaviors all day long in all types of social and environmental situations. This is kind of the exception that proves the rule. This was a young lady who hit herself or banged her head against objects 20,932 times the first day we admitted her to the inpatient unit at Hopkins. And we know that because we're obsessive about counting behaviors and seeing how much it occurs. And we counted it, and we decided we didn't need to keep her, we didn't need an extended baseline with this individual. You can see her cauliflower ears, her enlarged nose. She had scar tissue all across her head. but she was one of the very, very rare cases that it occurred all the time. Okay, another individual, this is a young lady with Cornelia de Lange syndrome, who would go sometimes a week, sometimes 2 weeks without any self-injurious behavior, and then we would see periods of agitation, manic-like behavior, very rapid sort of emotional responses, and she, during these periods, would run and seek out hard objects to hit her head against, and she did this by hitting her head against the tap on a tub. And as bad as that looks, if you look at the x-ray, she was about to compromise her skull, which placed her at risk of immediate death. Okay.
This video shows Dylan, a 7-year-old with autism and severe self-injurious behavior. The video was made by Dylan's parents to show how severe behavior disorders negatively impact the child and his or her family, and also show how effective treatment can dramatically improve their lives. Dylan was literally attached to his mother all the time. She couldn't put him down to go to the bathroom or even to go to sleep. They were physically attached like this because whenever she put him down, he engaged in self-injurious behavior. As an example, she is now going to try and put him down for a few minutes so she can make lunch. As you can see, he immediately displays severe self-injurious behavior.
I have no idea what he does. It's a typical behavior. A lot of times I do put him in a chair, but he didn't continue. And so he came up flat and stuff.
These are hard plastic walls. Dylan has to bang his head exceedingly hard to produce these holes. Head banging of this intensity over time can result in brain damage or detached retinas and blindness. This scene shows how these destructive behaviors affect not only Dylan and his mother, but also the other members of the family. Dylan's brother is at an age where at this time of the morning he might typically be watching cartoons while he waits for the school bus to come. Instead, he is asked to restrain Dylan to help prevent the self-injurious behavior. This scene is the same as the beginning scene, except that Dylan has now undergone 3 months of intensive treatment, and his parents have been trained to implement the treatment. Mom's about to make lunch. Before she does, she puts out a card to signal to Dylan that he can have her attention, but for appropriate behavior. Dylan doesn't speak, so he hands a card to his mother that shows he and his mother playing together. Now, rather than holding on to him and attending to him all day long, she gives him 1 minute of high-quality attention. Dylan is about to gesture to his mother with his left hand that he wants her to go to the play area with him. There he goes. Now Mom will signal back and tell Dylan that he has to wait. And now Dylan is able to separate from his mother and go and play independently while his mother makes lunch, something he was never able to do before treatment.
Okay, so the process that we went through with Dylan is pretty typical. We do our analysis to try and understand what the purpose or function of the behavior is, and in Dylan's case it wasn't too difficult to figure out that the purpose of his behavior was to gain and maintain his mother's constant attention. If his mother's attention wasn't available and other individuals was okay as well, and anytime he wasn't getting attention he was hitting himself. So our analyses showed that. Once we were armed with that information, we then designed an intervention to specifically address that function. And that was to teach Dylan that self-injurious behavior no longer produced adult attention, and that he could gain adult attention through more appropriate behavior. And for Dylan, it was handing over a picture card. And when we initially taught him that, handing over the picture card worked like magic. Every time he handed it over, he got attention immediately. But that wasn't very practical. That wouldn't work for the family. It was a little bit better than carrying him around on her hip, but he was still demanding constant attention. So the next step in the process was to teach Dylan you can't always get what you want. We did that through a variety of procedures, the most important of which was to teach Dylan when the card was out and visible, attention was available. And when we put the card away, attention was unavailable. And initially, we'd put the card away for just a few seconds at a time, and we gradually extended that period to when he was discharged. The card would come out once every 15 to 30 minutes, and he could exchange it for 1 minute of high quality of attention. And that was a schedule that his mother could easily maintain, one that could easily be maintained in a classroom. And so that's our basic process, is try to understand what variables are affecting the behavior, address those things, and then work to make the program as practical as we possibly can so that it's going to be carried out in the home and it's going to be carried out in the school and other settings. Okay, so how do we look at these functions in a very systematic and data-based way and try to figure out what is it that's going on with the behavior, and then how can we use that to design an effective intervention? And so this is a model that we've developed to look at a functional analysis and then proceed through a systematic set of steps in order to identify the function. And we don't always find it the first time we look, and so this is a model that helps us proceed in a data-based manner. Okay. What I just talked about with Dylan is one where there was a clear social function. In this case, the purpose of the behavior was to gain adult attention. And this is an example of such a functional analysis. And so what this is that we put the individual in these test conditions that simulate what might go on in the natural environment, but do it in a highly controlled manner. And so in the attention condition, we have our therapists sit in a chair. There's some not great toys, but toys out that the child is available to the child, and the therapist diverts their attention, usually just reads a magazine and ignores the child. So now the child is essentially deprived of attention. It's analogous to when mom or dad have to talk on the phone, balance the checkbook, cook dinner, those sorts of things, where their attention is diverted away from the child. And if that is a problematic situation, if that's a trigger, we're likely to see problem behavior in that. And what the therapist then does is then puts their magazine down and goes and attends to the child, says, don't do that, you might hurt yourself, may rub the child where they've hit themselves, or if it's aggression, saying, don't do that, that hurts. And the purpose of this is to test whether the delivery of attention in this format is reinforcing the problem behavior. In the demand condition, like I explained before, we give the child some non-preferred tasks to do. We may guide them to help them do it. If the child does something inappropriate, one of the target behaviors, knocks the materials off the table or hits themselves, we back off and say, okay, give them a chance to calm down. And if this is reinforcing the behavior, we're going to see high rates in the demand conditions. We have a test for a tangible condition that I talked a little bit about. And then the ignore condition or alone condition is one where we're most likely to see stereotypic or automatically reinforced behavior. Essentially, when somebody doesn't have anything else to do, they're more likely to engage in stereotypic self-stimulatory behavior. And our play condition is our control condition. And so this is just an example of a treatment where after getting a functional analysis, similar to what was done with Dylan, we replace the behavior with the communication response. Problem behavior decreases to near zero levels. We'll typically go back to baseline to verify that it was our treatment that was responsible for the change in behavior, and then reinstitute the treatment, and then go through those other phases as I talked about in terms of making the treatment practical for the family to implement. Okay, so the next step in our data-driven process is if we get high rates of problem behavior across all, in the alone condition. I'm having trouble reading it on my screen here, sorry. In the alone condition, this is, again, typically one where we think the behavior might be automatically maintained or automatically reinforced. A good example of that often is pica, and pica involves the repeated ingestion of inedible substances. Pica is the Latin word for magpie, a species of bird that will eat almost anything. That's where it comes from. And pica is often underestimated in terms of its seriousness as a problem, because all of our kids had this when they were real little, and so we kept the environment safe and protected them until they learned not to do that behavior. But if you think about somebody where this is a chronic problem, can often go on into adulthood and may be very targeted on certain types of materials. We've had individuals that seek out and eat glass, individuals that focus on metal objects, that eat carpet, eat a variety of things. And when this has been looked at across populations of individuals with developmental disabilities, the risks of death associated with pica are roughly equivalent to heart disease. I don't know if you can see this one. Can you see that? This was a young man who went after metal objects, and he happened to swallow a safety pin that then opened in his esophagus. And I often say that the most challenging part of my treating kids with autism and treating kids with severe behavior problems is getting paid to treat these problems because we frequently have difficulties with the insurance company paying for these specialized services. When we send in the x-ray showing this with this individual, this was one where we had absolutely no problem getting the individual cleared. So back to the issue of pica and doing the functional analysis. This was an individual that presented with a very specific type of pica, a young man who sought out and ate cigarette butts and would go anywhere and would be very secretive about trying to sneak them if someone wasn't watching. And so we did our analysis, and we get this pattern of the behavior occurring primarily when the individual was alone, suggesting that it may be automatically reinforced. And then we tried to figure out what might be reinforcing about that, and our hypothesis was that the nicotine in the cigarettes were responsible for the source of automatic reinforcement. And so what you see in this case is we compare cigarettes that have tobacco in them with herbal cigarettes. And what you see when we do the ones with herbal cigarettes, that is what's called an extinction run. That is where the behavior starts out very high and over time gradually reduces to low levels. We then did a series of what we call preference assessments to see what parts of the cigarette the individual most preferred. And what you see is this was an individual that highly preferred the tobacco components of the cigarette to the other parts of it, all consistent with our hypothesis that the source of automatic reinforcement was the nicotine in the tobacco. And then we did a treatment evaluation and did baseline. We have high rates. We go to it says NCF, that just stands for non-contingent food. So prior to the onset of functional analysis methods such as this, a common treatment for pica was just to give them something else to eat or put it in their mouth. We suspected that that wouldn't work if the function of the behavior was to get access to nicotine. Anybody that smoked, I did a long time ago, but eating may substitute for smoking for a short period of time, but eventually you go back and have the cigarette. And so what we saw was not much of an effect of that intervention. We then compared it with one where we interrupted the response reinforcer relation, reduced the behavior to near zero levels. So again, where the use of a functional analysis leads to a very specific intervention, in this case, a very effective intervention. Okay, so another pattern that we may see in the functional analysis is where we have high rates of problem behavior across all of our conditions, and there's a couple of possibilities here. One is that we have what's called multiple treatment interference. So we have somebody that's not discriminating between the different conditions, and so what's happening in one condition may be affecting what's happening in the other condition, and we have to simplify our analysis. And so this is an example where we're seeing lots of variable and different rates and different conditions. We then go to what is called a pairwise analysis, where we just compare each test condition with our control condition, and we see that this is a case where, yes, indeed, we have what's called multiply controlled behavior. The purpose of this behavior was to get attention, to get access to tangible items, and also to escape from non-preferred demands. And this would be a case where we would have to design interventions for each of those functions. Another situation that sometimes comes up is we bring the individual in, we put them in our kind of standard conditions, and we don't see much. And when we don't see much in our behavior analytic term, this means that the establishing operation isn't present. Or the more vernacular term is the trigger isn't there. We aren't setting up the situation that is likely to trigger the problem behavior. And so here's an example where we're getting some behavior, but it's not consistent. Sometimes we get it, sometimes we don't, and we're getting it in different types of conditions. And so we've developed a set of procedures for looking at what we call more idiosyncratic functions of problem behavior. And typically that involves more detailed staff and parent interviews, collecting what's called ABC data, and that's just basically having the individuals in the natural environment, the parents or other caregivers, whenever a problem behavior occurs, to write down A, what was the antecedent, or what happened just before the behavior occurred, what was the behavior, and then what followed, what was the consequence, what happened right after that. And what we've added to this in our research is to then do very targeted naturalistic observations. We're currently doing some research on putting video cameras in the home, being able to collect large volumes of data, and then very efficient ways of reducing that data to really focus on problem situations. That would be a whole other talk to talk about that. But essentially, we can currently take data in the natural environment with a camera and then examine that data at about a 10-to-1 ratio. So we can examine 10 hours of data in about 1 hour's time, which gives us a whole lot more access to what's going on in the natural environment, to help us find these idiosyncratic functions, and also it appears to be very helpful in identifying problems that didn't come up initially when the parents told us what they thought were the problems. We then do what we call our probe sessions, and the goal here is just to, if we identify something and say, we think this is the trigger, we'll set up that situation, do a real brief 1 or 2 minute session, see if we can produce that problem. A little while later we'll do it again, and if we can make it happen 2 or 3 times in a row, then we design a specific functional analysis to test the hypothesis that we've developed. And this is an example in which a common problem reported in the literature for individuals with autism is that they have difficulties with transitions. This was a case where we observed this and came up with 3 possible hypotheses. One is that the transitions elicit problem behavior, and that's how it's been described in the literature in a number of places. A second possibility is that just change itself is an aversive event for individuals with autism, or many individuals with autism, such that keeping things the same is a good thing. When you try to change something, even if it's a small change, it may, again, be a trigger for problem behavior. And then the last thing is that we often see that kids with autism entertain themselves, they find objects, they do things, and very frequently when we make a transition, we're getting them to stop that high preference activity and asking them to do something that we want them to do, which may not be a high preference activity. And so we designed our intervention, or designed our analysis to test these 3 hypotheses. And what we did was to take some tasks that were typically involved in transition, and we did a preference assessment to identify high, medium, and low preference tasks, and you can see them, they're labeled as H, M, and L up there. And then we set up our analysis whereby we started out in one type of activity, and then after they were doing it for about a minute, we said, okay, it's time to change, we're going to do this. And so in the first one, we said we're going to change from what was one of the moderate preference activities to a lower preference activity, and what you see there is that immediately triggered problem behavior, but when we were going from that same moderate activity to a higher preference activity, we saw no problem behavior. And basically across all of those different tests that we did, almost exclusively we saw problem behavior when we were going from a less preferred activity, from a more preferred activity to a less preferred activity. So this was an individual for whom change itself wasn't the problem, it was what they were changing to. Well, we've done similar analyses with other kids where going from a moderate to a moderate, not changing whether it's more preferred or less preferred, may evoke problem behavior. So that there are some kids for whom the change itself is the problem, and others it's more a function of what we're asking them to change to. And so this just shows a treatment that we developed based on these principles, where we increased compliance and decreased problem behavior across 2 different types of tasks, and those were the low preference tasks. And here's our summary of, these were the first 40 cases where we used this basic model, data-driven model, and what we found was that we identified social positive reinforcement in roughly almost 60% of the cases, automatic reinforcement in just a couple of cases, and then in the other 15 cases, we had to go to our secondary analyses, and in all of those cases, we were able to find a function, either an idiosyncratic function or it being pervasive automatic reinforcement where it occurs kind of across all of our test conditions. Okay, a specific area that we have done some research on is looking at idiosyncratic functions that may be highly related to autistic symptomatology involving automatic reinforcement. And so what we see in kids with autism is that some high probability responses persist without any social reinforcement. And again, these are said to produce their own reinforcement automatically, things like rituals, stereotypies, picking everything up and smelling it, looking at and spinning objects. And some aberrant behaviors are high probability responses, and what we know from both basic literature and some applied literature is that when access to high probability responses occur following a lower probability response, that lower probability response is going to increase. And so we've applied this basic model to these ritualistic behaviors when we've seen individuals who have a combination of real severe destructive behavior and high levels of stereotypic behavior. And the basic model is that interruption of their autistic rituals or stereotypies excuse me, may produce responses typically associated with extinction, where we're removing a reinforcing activity. A child that likes to go like this and we're telling him to stop that, they may get mad and do something inappropriate, hit themselves. The natural response of a parent would be, well, I'd rather have my child do this than do this. And so they may stop interrupting the response, and that may actually reinforce the destructive behavior and make it more likely when we try to interrupt their stereotypic responses in the future. And so this is another case where we have low levels of problem behavior, meaning we haven't found the trigger or the establishing operation. But one of the things that we noted during the analysis was very high rates of stereotypic behavior. And we did our descriptive assessments, and we came up with two situations that seemed to be related to problem behavior. One was where a staff member or parent or somebody was interacting with the child. They'd do something inappropriate, usually aggression, and the individual would back off and leave them alone. And so one possibility was that this was an individual that social withdrawal or having people go away, social escape, was reinforcing the problem behavior. But that wasn't the whole story, because one of the things that was in place for this individual, this was somebody with high rates of stereotypy, and their treatment protocol was to interrupt the stereotypic behavior. And so when we started our analysis, we said, okay, the person engages in aggression, we back off and leave them alone, and typically what they immediately did was go back to their stereotypic behavior. And this was an individual that would take and tap things. We then, in our next phase, had where aggression was placed on extinction. That is, now, when the individual engaged in aggression, we didn't back off. We just did not. We continued to interrupt their stereotypic behavior. And what you see is aggression, although went down to 0, we go back to where it produces social isolation. The person leaves, and back to aggression, and it reduces again. So to look at this aspect of whether or not the purpose of the behavior is to get us to go away, or to get us to go away in order so that they can resume their stereotypic behavior, we set up this secondary analysis. And so in one condition, we're interrupting stereotypy, and if the individual engages in aggression, we go away and leave them alone, and so they're able to resume their stereotypic behavior. And in the other situation, we, again, if they engage in engage in aggression, we go away. But while we're with them, we're not interrupting their stereotypic behavior. And what this shows us is it's only when we are interrupting their stereotypic behavior that getting us to go away is a reinforcing event. So this is a situation where our analyses were able to tease out that the real function of the behavior was not leave me alone, but leave me alone so I can engage in stereotypic behavior. And basically the same thing happened in our escape condition, where it looked like initially that the problem behavior was related to presenting tasks, but what we learned was that escape function only worked when we were blocking their stereotypic behavior. They were perfectly tolerant of us introducing tasks and working with them as long as we didn't block their stereotypic behavior. The aggression and other destructive behaviors decreased as long as we didn't interrupt their stereotypic behavior. So this is a case that illustrates that destructive behavior can be maintained by contingent access to stereotypic behavior, and sometimes they may falsely appear to be maintained by escape from demands or avoidance of social interaction. Okay, I'll do just a little bit more. Another thing that we see is this was a young man who engaged in really, really high rate ritualistic behavior. And to give you an example of how serious it was, the bedtime routine for this family was when it was time for him to go to bed, the parents would bring him into the living room. Mom would lay down on the floor. He would lay down perpendicular and put his head on his mom's stomach. She would be kind of like his pillow. And then Dad would kneel over him. And they would stay in that position until he fell asleep, because if they didn't follow this ritual or routine, he immediately engaged in very severe self-injurious behavior. When he would come to a doctor's office, he would want to rearrange where all the furniture went and who sat in one chair. And obviously that can be very disruptive to that type of situation. And so we did an analysis where when he had free access to rituals, he could arrange the things and do his rituals basically the way he wanted. We had no problem behavior. When we interrupted his rituals, in the next phase we see high rates. Go back to where he has free access to his rituals, it goes down. Again, contingent access, it goes up again. We did a naturalistic analysis with the parents, and what we saw with the parents is that they just didn't interrupt his rituals. And so in the next phase we used a bug in the ear, and we instructed the parent to do that, and immediately the problem behavior went up. And so our treatment was to, initially, was a FCT-based treatment. So where we did initially was we taught him to hand a card over. If he handed the card over, we would allow him to put the furniture and various things back the way he wanted to. That reduced his problem behavior, but we still had someone who was doing all this ritualistic behavior. And so the next step was to start to teach him to tolerate periods of time where we were going to interrupt his rituals. That's the second phase there. And we had two conditions, one in which there was no alternative ritualistic behavior, and then another one where we got him these little toys that he put on his fingers that he liked to play with in a very ritualistic way, but it looked a lot more normalized than moving furniture around, etc. And what you see is that he was able to tolerate that much better. We then started to extend the amount of time he would tolerate these periods of disruption, and then generalized it to a variety of situations. And I think I have gone a long time. How are we on time? Pardon? About done. Okay. So I will stop there. I think the basic idea here is one in which we try to identify what's going on in the environment that may be triggering and reinforcing the behavior. Sometimes that is easy to figure out, and sometimes it's real difficult. But we've developed a set of procedures where we can do that and help us to understand things like specific behaviors that we see in children with autism. Thank you.
Well, that was very interesting and complex, I think, at the same time. Okay, we have one last speaker, and then we're going to have questions and answers. All the speakers will be up on the panel.
Okay.
So I'm introducing Rob Fletcher. I'm going to read it. He is the CEO of NADD, which is the National Association for the Dually Diagnosed. He started that with the support and encouragement of Frank Mendelacino in 1983. Let's see. Rob Fletcher's vision and leadership has brought NAD to a position where it is recognized as the world's leading organization in providing educational resources, training, consultation, and conferences. This is Rob.
Thank you. The role of specialized training in dual diagnosis. Well, in my talk, it's going to be relatively brief. I'm not going to talk about statistics. I'm not going to show you charts or any figures. So it's not that model. It's more of a model of passion for the mission model. And I think that's in line with what Frank was all about. Frank, the most influential person in the field of dual diagnosis, then as well as currently. Steve mentioned some pieces, attributes about Frank that he's... Did you steal this slide? It's the same picture anyway. It's kind of interesting. We have a couple of pictures that may be the same, and we didn't share our slides. I know it all went to Shelley, but Shelley didn't pass on Steve's slides to me. But we all know that he was a policymaker, a researcher, an author, and a clinician. Now, most people who become into a state of considered authority in the field of dual diagnosis generally concentrate in one particular domain. It may be doing psychiatric assessment and diagnostic work. It may be developing a modified psychotherapy approach for people with a dual diagnosis. It may be somebody working in the forensic arena regarding persons with a dual diagnosis. It may be working in programmatic or public policy areas. Frank was able to weave in out with excellence in all of those areas. It was mentioned earlier that he was a mentor. He was certainly a mentor of mine. He helped build what NAD is about and certainly was influential in my career. He was a mentor to me, although I was a few thousand miles away, and I considered him a very, very fond friend. So giving tribute to Frank is an honor. Frank helped with the founding of NADD, formerly called the National Association for the Dually Diagnosed, now just NADD. So this is an earlier slide when probably before even the organization was organized with bylaws and elected officers and so forth. This looks like a hallway conversation. I think it was back in 1983. We were incorporated in 1984. And it's just a hallway conversation. This was, I think, a year or two after we became formed. Frank was the first elected president of NADD there he is. Again, left and right, this dyslexic thing, a little variable, getting in the way, with Robert Sovner, also a very influential psychiatrist who has also passed in way too early. Well, what is NAD? As I said, formerly called the National Association for the Dually Diagnosed. Well, there was... Okay. In about 1978, I started having, or 77, conversations with Frank. I had an intense interest in the whole area of dual diagnosis. I established the first day treatment program in the United States for people who have a dual diagnosis. So I'm very interested. I started reading everything that was written on the subject matter. And there was obviously, in those days, as there still is, a paucity of literature, and certainly a paucity of research literature concerning this underserved population. But what was out there was written primarily by Dr. Frank Mendelosino. And he wrote across, as I mentioned, a number of different domains: assessment, treatment, services, psychotherapy, forensic systems issues. And by that time, in the mid or late 1970s, he was certainly world-renowned and traveled all over the world providing consultation services on this subject. So in about in the early 1980s, by then we've had frequent conversations, mainly over the phone. He brought me to different conferences. He brought me to World Psychiatric Association. By the way, I'm not an MD. I'm a social worker by training with a doctorate in social work management. But we had a relationship, and he wanted me to talk about this day treatment program that I had developed, and I did that. We continued our conversations. One day I called. I said, you know, Frank, you and I talk, and we get together. We talk with Robert Sovner, and we talk with a couple other people that have an intense passion and interest in this field. But what we need to do is develop a national forum where we could communicate with each other, where we could exchange ideas, where there would be a platform and a forum where we could have a conversation about the various clinical, programmatic, and policy issues concerning this population. So I said, Frank, what do you think if I worked on developing a national organization? He said, Rob, go for it, go for it. So I did, and he lent his prestige and his time, his energy and his expertise and his passion. He would come to the little town of Kingston, New York, which is in upstate New York in the Catskill Mountains, to come to meetings. The first set of meetings were with what I call the Ad Hoc Advisory Council, and then from there it became more formal, and he was the first elected president. Well, NAD is a non-for-profit organization designed to promote interest, services, research, and policy development on behalf of individuals who have a dual diagnosis of a psychiatric disorder co-occurring with an intellectual disability. Our mission statement: to advance mental wellness for persons with developmental disabilities through the promotion of excellence in mental health care. So we have set out initially to bridge the gap between the developmental and mental health sectors by the promotion of mental health excellence within the existing developmental disability structure. Here's a couple pictures of Frank at some conferences, and any of you who have had the opportunity to observe Frank speak, he was the most dynamic speaker, most dynamic person actually I have ever met, and people would just sit there with their tongues out waiting for the next word that Frank had to say. He could really captivate an audience like no other. Here's a picture of the board of directors, I think in the early 1980s on the left side. Frank there with a couple of board members. Are almost sitting on his lap, I'm not sure. And I think the executive board at that point in time, some of you may know of Steve Reese, Robert Crabb, Dorothy Griffiths, Terry McNellis. Here's a picture on the left side, Bill Gardner, still working in the field of developmental disabilities and mental health issues. Frank in the middle and myself on the other side. And the other picture, Dr. Jack Stark. I'd like to recognize Dr. Would you stand up, Jack, please? Jack worked very intensely with Frank throughout the 70s and the 80s. And I recall one of the first times I heard them speak, they came to New York. I think it was at Valhalla. And at that point in time, I was interested in setting up NAD, and I set up a little booth and gave information about NAD, and it was free membership, and Jack and Frank lent their prestige to help form the organization. This is a picture of Jack when he was the recipient of the annual Frank J. Mendelosino Award for Excellence bestowed to Jack in 1993. This is a picture of Earl Lotion, who also had an association with Frank, receiving the Frank J. Mendelocino Award for Excellence in 2007. And our own keynote lecturer this morning, Jarrett Barnhill, showing off his Frank J. Mendelocino Award for Excellence he received in 2008. Well, the value of specialized training. Why is specialized training so important? And of course, Steve gave some cogent words about that. But I'd like to talk about not just psychiatry. How many people here are not psychiatrists? How many people here are not MDs? Any social workers? All right. The value of specialized training. We have, and historically have had and still have, and we really haven't moved all that much further, but we had made some incremental gains. So we have these silos. We have the developmental disability structure with its own eligibility criteria, funding sources, and eligibility criteria to getting into services, funding streams, and on the other side, a similar type of silo in the developmental disability system. Most of these are regulated by state agencies, and the state agencies really have any meaningful level of collaboration or cooperation between the two systems. The people in one silo do not know what the people in the other silo know. So what we try to do in NAD, whether it's clinical or programmatic or public policy, is try to work in a way that conceptually, at minimum conceptually, brings these silos together, where we try to permeate these walls of the silo so there can be some collaboration between the two silos. It was mentioned earlier about 1/3 of individuals who have a developmental disability also have a psychiatric disorder. Steve quoted about 1 million people. Stephen Reese, another well-known researcher, quotes 1.5 million people. I think 1 million people are those that are in services, and the 1.5 million are the population in general, some of which are not receiving any services. People with a dual diagnosis often fall through the cracks in the service delivery systems because they don't fit neatly into one silo or the other silo. And one silo says, that's your responsibility. And the other silo says, that's your responsibility. And often they fall through the cracks. So I think the role of specialized training in dual diagnosis is trying to bring together in some kind of collaborative, shared fashion the technologies and treatments that we know in the behavioral health field. We know how to do assessments. We know how to do various types of treatments. All we need to know, we need to tweak it a little bit, but we need to know on the other side the whole developmental perspective of the individual, which the IDD field has down pretty well. The IDD field, intellectual developmental disability field, that silo, doesn't know a whole lot about signs and symptoms that may be indicative of psychopathology in persons with an intellectual disability. We don't expect, we don't want even the staff in the IDD field to be experts in psychopathology. But what we do want them to know is something about how to recognize symptoms and signs that may be indicative of a psychiatric disorder. And on the mental health side, clinicians need to know mental health technology, but from a developmental perspective. Is it a behavioral problem or is it a psychiatric symptom? And actually that's a false dichotomy, because behavioral problems, challenging problems, whatever you want to, whatever term you use, usually co-occur with a psychiatric disorder. Behavioral problems, as Robert Sovner said, rarely occur alone. It's usually associated with something else, some behavioral health phenomena. So understanding the nature of psychopathology in persons with IDD promotes appropriate assessment, diagnosis, and treatment. I think on the IDD side, there's an over-reliance on the expression of behavioral challenges or problems as being something that is triggered by only the external environment, and insufficient consideration to look at what might be promoting the behavioral problem or influencing the behavioral problem from an internal state. On the other hand, mental health people tend to first may look at the first line of intervention that it's only an internal problem without sufficient look at the complexity and the holistic perspective of it, and seeing how an external problem may be influencing an internal state and vice versa. So we need to have a better understanding, a mutual understanding about the two systems, about the two philosophies, about the two separate technologies, and bring them into some kind of collaborative fashion. That's what NAD has been doing for the last near 30 years. We look at things from a biopsychosocial perspective, but what's needed in the unique perspective of specialized training is looking at things not only from a biopsychosocial perspective, but from a developmental biopsychosocial perspective. People who have, for example, a severe level of intellectual disability and say bipolar, say major depression, may manifest the expression of the depression differently than a person, say, who has mild level of intellectual disability, or someone who has no intellectual disability at all. So we always need to look at all our work from a developmental biopsychosocial perspective. We need to, in terms of specialized training, one of the things that NAD does is disseminate information. This is some books that we have on psychotherapy and adapting, modifying to some degree, tweaking psychotherapy approaches and techniques to meet the needs of people who have an intellectual disability, to use the existing principles of psychotherapy, whether it be cognitive behavioral therapy or whatever theoretical framework you have, but to make it useful in consideration of the expressive and receptive language skill of the individual that we're serving. Another thing that we do is looking at psychopharmacology, drug treatment, and what needs to be tweaked a little bit. We know of the psychopharmacology practices and principles that apply to the neurotypical population, but as clinicians, I think we also need to look at how it can be tweaked and best be used and utilized optimally for people of an intellectual disability. So NAD has published a number of books on psychopharmacology. Other areas of specialized training, I think in core areas, is in assessment and diagnostic procedures and principles. And in that regard, there's a number of different screening tools like the Rescreen for Maladaptive Behavior and others, as well as the recently developed Diagnostic Manual for Persons with Intellectual Disability. We need to understand the presentation of psychiatric disorders. As I mentioned, psychiatric disorders, even a singular psychiatric disorder, the example I used before was depression, can be manifested differently in people with severe, profound levels as compared to people with mild and moderate levels of intellectual disability. What may look like a behavioral problem may have its underlying root in a psychiatric disorder. And so we really need to look much more deeply than what's being presented only at the surface. We need to, other core areas of training are in psychopharmacology, psychotherapy, behavioral therapy, and other treatment technologies. We need to look at specialized training really across the board in a very holistic way from a systems perspective in the criminal justice system, impact on families, social and sexuality issues, substance abuse issues, and we need to work towards a better paradigm of systems cooperation and systems collaboration. And that is work in advocacy. That is work that NAD has been doing for nearly 30 years. That is work that's embedded in the belief and the values of Frank J. Mendelocino. Well, what does NAD do? We publish a periodical called the NAD Bulletin. It comes out 6 times a year. We do a lot of conferences and trainings, international conferences, annual conferences, statewide conferences. We produce a large number of different types of educational materials. We have a book publishing company called the NAD Press. We have the largest selection of books found anywhere worldwide in the field of dual diagnosis, and we provide consultation services. The types of articles, this is a recent table of contents from our bulletin, the NAD Bulletin. We have articles such as this is Resiliency and Challenges of Families, Complex Post-Traumatic Stress Disorder, Neuroscience Reviews Bipolar, written by our own Jared Barnhill, Public Policy. We have a public policy article at each issue, and we have something on direct support professionals. We're in the process of developing a certification accreditation program. One leg of that is for direct support professionals, and an article is written on that. We do a lot of training, as I mentioned, a lot of conferences. Our next conference will be in Nashville, Tennessee, this coming October. These are just some last few annual conferences that we've had. We, several years ago, embarked on the development of a research journal, publishing original scholarly work in the field of dual diagnosis. It's the only such dedicated research journal of its kind found worldwide. We have a education and training catalog that not only do we have the NAD books, but a large number of other types of material offered through CD-ROMs or computer-based training and so forth. One of the most important, I think, seminal works that we have developed is the DMID, Diagnostic Manual for Persons with Intellectual Disabilities, which was designed to provide a more accurate psychiatric diagnosis, and it was done in association with the American Psychiatric Association. Essentially uses the same nosology system, the same diagnostic categories as found in the DSM-4TR, but how we come up with those particular diagnoses is much different. There are a number of various types, kinds, and types of modifications to criteria subsets. So the nosology categories are the same. The codification for insurance purposes and so forth is the same as what you see in the DSM-4TR, but how you arrive at that diagnosis, because this book was essentially developed because we wanted to develop a diagnostic manual for individuals who have no or very limited verbal skills. So when you go to a psychiatrist and say, "Doc, I don't feel good, I don't want to go to work, I have to get up in the morning, I really don't want to get up in the morning, I want to stay in bed, I come home and I go to bed, and I don't interact much with the family, and I just feel lousy." Diagnosis? What is it? What could it be? Depression. Okay, now, I'm a person who has no verbal skills. How you, as a psychiatrist or a clinician, can assess my signs and symptoms coming up with some diagnostic formulation? How are you going to do that? Not easy. So the DSM-4TR falls short on working with people effectively in a diagnostic way, people who have an intellectual disability. Thus, the development of the DMID. If people would like more information on this, they can go to www.dmid.org. Well, can't speak about specialized training without giving tribute to the late, great Frank J. Menelosino. If it wasn't for Frank, there would have been no NAD. I was just a lonely social worker in the 1970s, had an intense interest, but without lending the support from Frank, NAD would have never been established. So I give a full thank you and credit to Frank for lending his support in the founding of NADD. I thank you very much, and thank you for inviting me to be here.